First of all, wanted to remind you we are recording the session today, so please do not include any confidential patient health information during the discussion. On to our next slides here. If you do wish to receive a CME or CEU certificate, please enter your name into the chat box, or you can go ahead and unmute in just a moment and let us know who you are and where you're from, and I'll be sure to get that out to you. That will come from Michelle, second week of the month typically. We'd love for you to join the conversation on video and audio, so your mute and unmutes for both of those items are on the bottom left of your screen. So we'd love to have you unmuted for the discussion portion, so you do all have that capability. So please take advantage of that if you're able to. Our disclosure and accreditation statements are on the screen now. And Envision New Mexico is partnered with Molina Healthcare and Blue Cross Blue Shield New Mexico to offer case consultations with our expert panels for some of our sessions. Get in touch with us for more information on that. You can be reimbursed by Molina and Blue Cross if you have patients with those entities. So it is a significant amount and a pretty underutilized service. So please take advantage of that if you're able to. And now's the time for roll call. If you have your microphone enabled, or you can unmute, bottom left of the screen once again, and let us know who you are and where you're from. Otherwise, I'll be monitoring the chat box. And I see we have Jane Beckley and Anna Lynn Tesh. And at this point, why don't we go ahead and introduce who is in the room. This is Kevin Werling, Systems Analyst here at Envision. I'm going to go ahead and zoom out and everybody can say their hellos. Let's start with Elena.
Elena Scherer, Senior Statistician at Envision New Mexico.
Andrea Anderson, QI Specialist here at Envision.
And I will go ahead and turn it over to Dr. Dan Rifkin, our presenter for today.
Well, thank you, Kevin. It's a pleasure to be here this afternoon to talk about the Student Health Questionnaire known as the SHQ, what to do with it, and why it's so important anyhow. I know Jane and others in the room here, so you probably know I'm a child and adolescent psychiatrist here in the Adolescent Division, UNM Pediatrics. I practice in the UNM School-Based Health Center program and the Pediatric Clinic at 3ACC. I also have the pleasure of working on resident education and also consulting here at Envision New Mexico, largely on projects that increase behavioral health service capacity in our state, and do so by supporting providers around the state with matters having to do with psychiatry and integrative behavioral health care. Our objectives for today's webinar is to identify the health, safety, and mental health and substance abuse screens, as well as strength, resiliency, and protective factor items embedded in the SHQ. That's a pretty big objective, so we'll spend quite a bit of time on that. That is looking at both the screening items that look for risk, as well as the items that indicate that there are strengths, resiliency, and protective factors. We're going to describe how the SHQ is used, and I'm also hoping that along the way and as we summarize, you'll appreciate the changes to the SHQ that have been made over the past decade. Well, why is the SHQ so important is what I really want to emphasize today. Whereas previously we've called this seminar or its predecessors, what's really led up to this presentation today, we used to refer to it as the nuts and bolts of the SHQ. I had the pleasure of presenting on this topic going back quite a ways in work that I got to do with the Office of School and Adolescent Health. Thereafter, a presentation of a similar nature was developed by the SHAs and SHMAs, the SHAs being the student health coordinators and the SHMAs being the student mental health coordinators in the schools. Thereafter, Chris Carrillo, school Office of School and Adolescent Health Behavioral Health Lead, and Paula LeSueur, then at the Office of School and Adolescent Health, both of whom came here to Envision. The three of us further developed the nuts and bolts of the SHQ. Looking at it from the perspective of integrative behavioral health, I'd like to talk with you now about the SHQ and why it is so important. Well, it's important because all school-based healthcare begins with screening. It's the first thing that we do, and it differs a lot from other kinds of care that is offered and delivered in other healthcare settings. The Student Health Questionnaire is a crucial component of the comprehensive care that we provide. It initiates this comprehensive care by screening all students in New Mexico Department of Health funded school-based health centers, and there are other school-based health centers around the state, such as through FQHCs, that are also screening for numerous health, safety, academic, behavioral health, and psychosocial risk factors. Those are the risk factors we look at more broadly. But why do we screen? Well, 2 out of the following 3 answers come from the behavioral health perspective, using the example of depression, which is also applicable to other risk factors. By the way, how do you like the screens that you've seen so far? Well, in talking about why do we screen, prevalence is a big one. There's been a figure of 2 million teens who are suffering from depression, which came out by the U.S. Preventive Services Task Force back in 2009. Simultaneously, there's been the Youth Risk and Behavioral Survey, which in New Mexico is called the Youth Risk and Resiliency Survey, which surveys high school students about their behaviors over the preceding year. And for those items that look at depression, there's a large number, roughly a third of youth who felt so sad or hopeless they stopped usual activities, symptom of depression. Also astonishing, approximately 16 to even 17% nationally that seriously attempted suicide. About 14% who planned a suicide attempt, and as much as 9% that actually attempted suicide 1 or more times. So this is a really important reason. Not only the prevalence, but also the facts about the severity of depression in youth here in New Mexico. And on the right-hand side in the brackets are those figures that correspond or were reported in the National 2013 YRBS. The YRBS and YRRS are conducted every other year. So sometime soon we'll be receiving the results of the 2015 surveys. Well, I mentioned earlier the U.S. Preventive Services Task Force. They came up with guidelines for annual teen depression screening, recommending that all teens ages 12 through 18 years of age be screened for major depressive disorder when systems are in place to ensure accurate diagnosis, treatment, and follow-up. And they point out that when followed by treatment, that those who screen positive can get help to improve potentially debilitating symptoms of persistent sadness, social isolation, school problems, even suicide. So we have prevalence, we have severity of symptoms, And then we also have guidelines that recommend annual depression screening. Also, we have standards put out by the Office of School and Adolescent Health, which direct school-based health centers to screen all students entering school-based health centers at the first visit, unless acuity interferes with doing so. And I'm looking to see where they had stated that too in administering at their first visit. If it's not administered because the student is acutely ill or in crisis, the SHQ should be administered at a scheduled visit within 30 days. So acute illness could be high fever, other acuity could be injury on the football field and having sustained a fracture. Acuity could also be suicidality and having crises around that. We sure wouldn't administer the student health questionnaire under those circumstances, but would want to make sure it is conducted within the next 30 days. Also, the OSA standards and benchmarks state that group administration of the SHQ is not advised. And we'll talk about this more about how to best administer the SHQ. But I'd like to describe a little bit more about the student health questionnaire. It's a multiphasic screen that contains multiple screening tools concerned with detecting multiple conditions or diseases by risk identification. The risk for each of these are determined by providers according to the risk factors indicated by students. Now, the SHQ is developed based on guidelines for adolescent preventive services known as the GAPS that were developed by the AMA and been promulgated ever since. Now, when you go to meetings, especially these national meetings of the School-Based Health Alliance and others, you may hear providers and others from other states talking about how they use a GAPS in their school-based health centers. But it's an important distinction that the GAPS is not the screen. The GAPS makes recommendations or contains recommendations and guidelines that make for the basis of the student health questionnaire. And it's interesting that this notion of the multiphasic screen has been around since the 1940s when public health professionals were recommending that as long as you're screening for tuberculosis, how about screening for some other conditions? Well, considering that the SHQ is a multiphasic screen, what else does it contain? And does the SHQ also detect strength, resiliency, and protective factors? And that's when we're going to look more closely at our first objective. Well, here's a listing of the screens that are embedded in the SHQ, both the high school and middle school versions. And again, these are screens, so we're detecting risk factors. There are 2 items that comprise the PHQ-2, modified for teens, that screen for depression. Likewise, there are 2 items that screen for anxiety. There's 1 item that screens for sleep difficulties, which can accompany depression and/or anxiety. There's also 2 items, 1 each that screen for suicidality and self-injurious behavior. There are also items for safety, victimization, and violence. There are items that screen for substance abuse. 6 of them comprise the CRAFT. And then there are numerous other screens listed here having to do with problems with school, relationships, family and friend relationship problems, other psychosocial stressors, sexual activity risk as far as sexually transmitted disease and pregnancy risk, as well as sexual orientation and gender identity. There also are health screens having to do with eating, weight and body image, tobacco, use, and screen time. And there also are places to indicate medical history for conditions like diabetes, asthma, seizures, etc. Well, here I would like to move on to the resiliency, strength, and protective factor items that are in the SHQ. We'll look at the SHQ in just a moment. On the left-hand side, there are actually the item numbers that will ask questions such as, who do you live with? Do you feel you can really talk to somebody, okay? Or who do you feel you can really talk to? What kind of, are there adults available? Health behaviors, such as eating fruits and vegetables, 5 servings a day, getting sufficient sleep, getting sufficient exercise. There are safety items, safe sex practices, asking about future plans and goals, and self-esteem. And then on the middle school version, asking these items A, B, and C. If somebody has at least one adult in their life who cares about them and feel that they can go to for help, have at least one friend or a group of friends that they feel comfortable with. And as they're gaining autonomy and independence, are they able to make more of their own decisions? Well, at this point, I would like to take a look at the SHQ and go to at least the high school version, which I think was handout number 1. There we go. Great. Here is the student health questionnaire. And I'm going to look and see, Kevin, can I scroll with? Great.
No, but yeah.
Great. So here we just talked about items that have to do with gender identification, as well as sexual orientation. By the way, in between, there's an item here that asks about race. And these follow a confidentiality statement, okay, that states that this is confidential and also has statements about limits to confidentiality. Except the only exceptions are if you're thinking about harming yourself or someone else, or if you're being harmed or abused. There are items having to do with home and school. Who do you live with was mentioned earlier. Who do you feel you can really talk to? Are you having any of the following problems at home, such as with violence, fighting, concerns with a family member, and an unemployed parent or guardian? With regard to school, missing school, suspension, problems with grades, bullying. Health behaviors, sufficient exercise. Now this item, number 5, is actually a risk factor about having excessive amounts of screen time. Numbers 6 through 9, well, I would say 6, 4, 6, and 7 are actually protective and resiliency factors mentioned earlier. And then there are a couple dental items about sufficient dental follow-up and symptoms of tooth pain. You can see safety have to do with wearing a seatbelt, wearing a helmet, okay, texting, surfing, or talking on the cell phone while driving. Being threatened, having a history of physical, sexual, or emotional abuse, having ever been hit, assaulted, carrying a weapon to protect yourself, which actually is not a protective factor, that's a risk factor. Because in most cases, an individual who confronts one has more experience with a weapon than that which the individual is carrying. Have you ever been in foster care or group home or been homeless? Have you ever been in jail or in a detention center? Are risk factors. Then we come to the 2 anxiety items, both the cognitive emotional aspect of anxiety. Do you often worry or feel like something bad might happen? And are you the somatic or physical aspect of anxiety? Are you often tense, stressed out, or have difficulty relaxing? Then there are the items in the current version of the PHQ-2 modified for teens that actually quantifies and scores both A, little interest or pleasure in doing things, and B, feeling down, depressed, irritable, or hopeless. Here, the modification is adding the word irritable to item B, as youth are often irritable when they're depressed and having dysphoria. The quantifying of PHQ-2 is one change from the last version, which merely had a yes or no answer to the questions. 22 is the item about suicidality. I'm sorry. Item 23 is the item about suicidality, and item 22 about self-injurious behavior. You can see the category here of relationships and sexual activity. Asking if somebody is sexually active. If they're not, one actually skips these items and moves on to health behaviors and substance abuse. Here's the item about tobacco and other forms of tobacco. And then there's the item that comes from the craft. The C in craft refers to, have you ever ridden in a car driven by someone, including yourself, who is high or using alcohol or drugs? And then the SHQ actually asks about substance use, whereas the craft is actually intended to pick up risk for substance abuse without directly asking one if they use substances. And the other parts of the acronym for craft are relax, using to relax or fit in. The A in craft, using when you're alone. 1 F in craft, forgetting when you're using alcohol or drugs. The second F in craft, about family or friends, advising you to cut down. And last, the T in craft, getting in trouble when you were using alcohol or drugs. And then lastly, do you have any concerns or questions about the size or shape of your body or your physical appearance? Asking about future plans and career goals and family goals. And then also asking about esteem. So you can see that there are a lot of items that are asked about in the SHQ. Also comment here where there's an asterisk, providers. These questions are from a validated scale, the PHQ-2 in the craft, that should be scored with appropriate follow-up for a positive screen. Well, I referred to the PHQ-2 being quantified. There is sufficient sensitivity and specificity that's been found in evidence basis for a score of 3 and above, indicating a positive screen. However, some are making a cutoff of 2 in order to cast a broader net when screening, and thereby at the expense of having some false positives. With the craft, a score of 2 or more indicates a positive screen. Thank you, Kevin. Great. So hopefully you've gotten to appreciate, at least on the high school version of the SHQ, these risk factors and strength, resiliency, and protective factor items that are embedded in the SHQ. From here on out, I'll refer to the strength, resiliency, and protective factor items as protective factors. Now, the SHQ is formatted such that there are 3 different versions. You saw the high school version. The middle school version is very similar. However, it has language compatible with early adolescent development. However, a couple of the pediatric residents, by the way, who have rotated through on their rotation, commented that they thought that the language in the middle school version was actually quite sophisticated. They were rather surprised. The elementary school version is administered for parents to complete. It's about 3 pages long, and we can take a look at that as well. I mentioned the confidentiality statement in the box at top. We do have Spanish questionnaires, and the high school and middle school versions are actually administered on an iPad, and the version of the SHQ is referred to as the ESHQ, and it's used in many school-based health centers. By the way, it's the majority of those that are funded by the Department of Health, plus some others, such as the Pewaukee School-Based Health Center and other school-based health centers that are operated by FQHCs are also using the ESHQ on the iPad. Well, what do we do with the SHQ? I'd like to look at that just after I show you an example of the elementary school version of the SHQ. We'll get to that later. You'll see, by the way, at the posting for today's presentation that there are these handouts, all 3 versions of, including all 3 versions of the SHQ and the PowerPoint that we're using to guiding our discussion. So you'll see confidentiality statement, family information, again, all of this filled out by parent, family medical history, family health habits. So this largely gives past medical history and family history to the provider. And then school history about performance, relationships with teachers, relationships with other students. And then it gets into other relationships such as with family and other friends and having hobbies and special interests. And then going a lot more into the use medical history. Okay. Thank you, Kevin. So if we can go to the PowerPoint again, let's talk about how the SHQ is best used. What do we do with the SHQ? Well, with us today is Jamie Duval from Apex. Actually, she's with us by video, and she's going to give us a little demonstration about administering the ESHQ on the iPad, and I dare say she does a good job of it. One moment. This is a new one for me too. I haven't attempted to embed a video into a webinar before. And I thought that this one that Jamie had put together, which I actually had to insert into my browser too, before Google had little reminders to go vote. And this is just about 3 minutes long.
Hello, this is Jamie with Apex and Apex Apps, and today I'm going to be showing you how to use the ESHQ. So you'll see the Start button, and when a patient comes in, you just want to click on Start and select whether or not they're going to do the high school or the middle school ESHQ. So you'll see a button pop up next to it. If you have more apps available, which you eventually will, like the PHQ-9 and Scared, you could select those in succession. So right now we just have the ESHQ. So tap a 1 and then click Start. And select the language and have the student fill everything in.
Now Jamie's actually going through.
Once
So
the
you're
student has
having
completed the
audio out
ESHQ,
there.
it'll bring them right back to the start page. To retrieve the records, go ahead and click on the lock in the top left-hand corner. Be prompted for your PIN number. And once again, you can get your PIN number from either the email I sent you, your coordinator should have a master list, or you can call me directly. So you'll notice the record that I just made was test craft. Go ahead and tap on that. You'll notice the menu is still the same: alert report, full report, edit, expire, or delete. Just a reminder, do not use the delete button unless it's a test record or a mistake. Deleting that record will take it off of our database as well. So go ahead and click alert report. And you notice that the craft flag is now embedded on the ESHQ reports, both on the alert report as well as the full report. So you can use the craft score for billing. If you have any questions about that, be sure to ask your
This will
coordinator
show
or
all of the
Brenda or one
responses
of your
to
quality
the
improvement
entire
coaches.
SHQ.
And close. I'm going to go back to the alert report. And you'll notice that the provider review is still in the same place that it was before. Click on review. And you'll see you get a positive craft flag. And as you're coming through, you can add your comments in. I want to remind you too that you can split the keyboard by grabbing onto the G and the H and sliding them apart. So that way you can see everything above. You notice everything's color coded, and the craft flags are in here too. So you'll see that all three of your craft flags show up right next to the question that they entered positively to. So you can leave your comments on that as well. And then print and send to box is still in the same spot as well. Either print, send PDF to box, or JPEG to box. It doesn't matter which one you send to box, it just depends on how you import it into your EHR. Thank you for watching this tutorial, and if you have any questions, please contact us at support@apexapps.org. Thank you.
Okay. All right, excellent. So I hope you all found that worthwhile. Unfortunately, it looks like Ilse was unable to hear the audio portion, and we couldn't hear it either here at Studio Envision. But it looks like Julian and Sandra, who also have joined us, as well as Anna Lynn, all had audio, which I think is great. For those who had audio, could you let us know if you found the video was worthwhile? Okay. And Ilse, you said you didn't see the question, but you were able to hear it. You were able to hear the video? Great. Okay, excellent. For all of you who would like to hear and see it again, this video link is in the PowerPoint for this webinar today, which you can access in the future from the calendar for Envision New Mexico. Thanks. So let's talk about how the SHQ is best administered. Because essentially everybody on the School-Based Health Center team has a role in administering the SHQ. And I would qualify that by saying the entire process from School-Based Health Center coordinators, assistants, and clerks actually administer the SHQ to students to fill out while they wait for a provider. Later, the provider will review and interpret the results with the student. There's, in many school-based health centers, a scripted opener, such as we would like you to fill out this form completely, but you can choose to skip questions you do not want to answer. Clinic staff will assist students who are having trouble by offering verbal explanations and reassurance of confidentiality. And because we find that students may not want to write a risk behavior, but willing to talk about it. On the other hand, providers often ask questions when reviewing the SHQ with the student because they may, on the other hand, be willing to write about it, but not want to talk about it. And there's some important considerations when administering the SHQ. It's to be administered at the first clinic visit, not prior to. That we do not attempt to administer too many of them, more than the number of students seen on a given date. And group administration of the SHQ is not advised. And I just want to comment a little bit more about our experience with these aspects. We found in our quality improvement initiative with school-based health centers that focused on the SHQ that in a number of instances, a paper SHQ was sent home with a student along with a registration form. The student then would fill it out before they returned to the clinic. Perhaps they would fill it out with a parent, which is not what it's intended for. On the other hand, when filling it out by themselves, they may have indicated a high risk factor, such as suicidality or self-injurious behavior, and we wouldn't want to lose sight of that SHQ by allowing it to sit in a backpack for a week before they have their appointment, or longer, or even get lost. About capacity, there have been some very zealous providers who've wanted to administer the SHQ to an entire group of students, say in a health class. And it may seem perfectly reasonable to do this to, say, 30 students, and we'll review those and interpret those in an hour, no problem. It ends up becoming a much greater undertaking than it may seem when really going over and reviewing it with students. And if a student indicates a serious risk factor like those mentioned earlier, that could prevent getting through the remainder of the SHQs before the students leave class. So the caveats about the number to administer, not advising group administration, really go hand in hand. And sometimes in clinic visits, it's been very tempting to add on a student at the end of the day and say, well, we'll start you with the SHQ and see what else we can offer you today, when the provider may not be available, in fact, to see the student that same day. By the way, the SHQ has been very helpful to administer for screening during the EPSTAT. The S in EPSTAT, I think it's early prevention, screening, diagnosis, and treatment. The SHQ can fulfill the S portion of EPSTAT very well. Well, there also are a number of provider responsibilities. I mentioned reviewing and interpreting on the date that it's administered. This is done by primary care, and that is medical as well as behavioral health providers, according to the OSA standards. Now, nurses have also reviewed and interpreted the SHQ in collaboration with these providers. And in our school-based health center program at UNM, we're currently about to pilot SHQ review and interpretation by our case managers, as we have a need to be providing more services while we do not have medical and behavioral health providers present at the site. We want to be sure to allow enough time to review, interpret, and respond to the SHQ during the visit. It's important that we document risk and protective factors in the completed SHQ. You saw that that's what Jamie was doing toward the end of the video, was actually reviewing these various sections, okay? And we also document the significant findings in the medical record. This is done in PowerChart. We have various templates that are used to do that. Many of us have wished that the SHQ could be downloaded in its entirety in the Power Chart or other EHR so that we don't have to duplicate our efforts. We sign and date the SHQ, and we plan the next steps for assessment, treatment, and follow-up before ending the visit. Now, the risk and protective factors are areas that are also indicated with health guidance in the school-based health center health maintenance record. And here's where I'd like to go to another one of our handouts for the SBHC health maintenance record. Thank you. Now, the paper version of the health maintenance record is one of the documents that's available from OSA as posted at the New Mexico Alliance for School-Based Healthcare, along with the SHQs. Nowadays, there are EHR versions of this, such as the health maintenance record that's in Power Chart at UNM, for example. But this is still available, as I said, for the left-hand side of a paper chart. And I find it important to mention because there's a section here about student health questionnaire. And each time that it's administered, it's dated, and there's an indication to know where the risk factors are, where there's no concern, such as in this individual, about relationships and sexual activity, and also about protective factors, such as development and future plans. The student seeks support, likes himself, and has future plans, as reviewed by Paul Provider, physician assistant. Okay. Thank you. Providers rely on their clinical judgment from their training and experience when reviewing and interpreting the SHQ to determine risk and plan the next steps that were mentioned earlier. And this process often reveals a need for team conferencing in what we refer to as wrap-up. And part of that can be revealing a need for consultation, which is one of the things that we do in team conference. Well, what's new with the SHQ? How about the changes over the years? This addresses our third objective. Well, there have been a lot of changes in the middle school and high school versions of the SHQ, whereas the elementary school version was last updated in 2010. iPad administration and review of the ESHQ in many school-based health centers is now what's done for both the high school and middle school versions. It's been shortened considerably to about 1 2/3 pages, yet has contained more screens, especially in the middle school version. Because the earlier longer versions for middle school contained 3 pages. The high school version used to be 6 pages long or 6 sides. Now we have 1 2/3 sides. So it's been remarkably condensed while containing more screens. It also has an evidence basis and is also based on empirical support from practice. Okay. And there's been removal of an open-ended question that used to be in the beginning of the longer paper versions, which was, why did you come to the clinic today? Known as the chief complaint or main reason for the visit. And this is to depart from a traditional medical visit when it's a screening visit, for example, and to decrease overlap with assessment. Because as many of you have seen me make the point about before, there's a distinction between screening and assessment. To screen is not to assess. A brief screening tool is shorter than the longer assessment instrument. And assessment instruments are administered as indicated by a positive screen. And that's where we have come up with this scheme for the integrated behavioral health, in which the screening tools we've been talking about in the SHQ, such as for anxiety and depression, when positive, indicate the administration of the assessment instrument, which is a PHQ-9 modified for teens for depression, and the SCARED, which is the assessment instrument for anxiety, which I have not been afraid to talk about in other installments of webinar series. Zzz. But in order to use these tools, I am glad to talk with you further, consult with you through telepsychiatry consultation, which is available 4 afternoons a week by appointment. I marked here that it's subject to change as schedules can change, such as on election day. And I have quite a bit of flexibility on Monday afternoons especially. So make your appointment, please, by contacting Janine by telephone or by email. You'll be given a phone call for scheduled consultation. And one of the things that we can talk about in consultation is how this scheme can be used, for example, screening for eating disorders, using a screening tool with the acronym SCOFF that I think is 6 items long, and an assessment instrument that I think is called the EAT-23, aptly 23 items long. It also is being used for the CRAFT, as we've talked about, as the screening tool in the SHQ. And for those sites that are working with the SBIRT project through Envision New Mexico, there is an assessment instrument referred to as the CHISPA. So in summary, the SHQ is an important multiphasic screening tool for health, safety, and behavioral health risk that also detects strength, resiliency, and protective factors. Best practices for SHQ use have been established based on OSA's standards and benchmarks, and also have an empirical and evidence base nowadays. There are numerous enhancements that have been made to the SHQ over the past decade. And for the identification of student depression, anxiety, and comorbidity, the SHQ initiates comprehensive integrated behavioral health services that we provide in school-based health centers. Here are references for your use, and I would like to call your attention to the first one, where the student health questionnaire and the standard for and benchmarks for school-based health centers, as well as other school-based health center documents from OSA, are available at this New Mexico Alliance for School-Based Healthcare website. Used to be referred to as the SBHC Toolkit. They are now listed under SBHC documents. Other of these references have been made in the slides that we've been viewing today. So I'd like to thank you and ask you if you have any questions, remarks, concerns, protests. There's a mention from Anna was interesting. Doubt I will have access to this technology, referring to the sound earlier.
I think it was when you were demonstrating the SHQ
Okay.
that she wasn't sure she would have technology.
But I think, or hopefully, Anna, the ESHQ administered on the iPad can become available to IHS sites in the future. I don't have the latest word on that. Anna, you had asked, is it recommended to do the SHQ at every visit? No, it actually is not, but it can be done at more than one visit when there is an indication, such as changes in a student's psychosocial situation, if there is a marked decline in students' presentation as evidenced by their appearance, their other aspects of their mental status, recent history of academic decline, and so forth, then it may be a good idea to administer the SHQ to screen once again for risk factors. Any other questions, concerns? Yes, Jane. Jade had commented about finding this very helpful, especially the emphasis on relationship with the provider in the administration. And that becomes very important. This is an instrument where it does not lose the provider's rapport with the patient. And actually, the SHQ can become an entree to developing rapport for further interview, moving on to assessment. It can also be an important adjunct when there already is a very good rapport and relationship established. I'd also like to comment and follow up to a discussion that I had with Ilse, the case manager at Van Buren Middle School and Washington Middle School-based health centers. Ilse had asked me after joining me during a review and interpretation of the SHQ about including limits to confidentiality. And I thought about that, Ilse, when noticing again that the confidentiality statement is at the beginning of the SHQ. And I think that by bringing up repeated statements about limiting confidentiality in particular circumstances, we might actually impede the process of obtaining information about risk as well as protective factors. Any other questions or concerns? Well, very good point. And we can ask the students, they'll say, if they've read the confidentiality statement at the beginning of the SHQ, okay? And we can ask them what their understanding of that is. Pardon my distraction as I have to tell them that to bug off for a moment. It'll say, do you think that would work for you? That would work. Okay. You know, reading the whole thing, I think, is a really good point, especially when I think we have kind of a pandemic of people not completely reading their emails. So often we receive communiques and documents or we distribute them and find out that they're not completely read. And then there's a whole idea of whether the language is understandable. And it becomes a very fine balance between giving a sufficient informed consent that includes mention of the limits to confidentiality that would be sufficient, it's necessary, and yet not too much. I'd also like to comment about an aspect of the SHQ that I was sharing with Julian, and that is that for me as a psychiatrist who trained and in my early career worked primarily with a clinical population, that would be young people who already had their behavioral health problem identified, and they were referred for further assessment and treatment. In that case, I would start out with using an assessment instrument if I used a tool at all. When coming to work in school-based healthcare 16 years ago, I got introduced to the SHQ, and at first was very questioning about what it was and what was its utility. And I think you can tell that I've become a great fan of the SHQ, and it didn't take me long. And it also got me to appreciate the public health approach that we take in school-based health centers, and how many of the referrals that I and my behavioral health colleagues, primarily therapists, receive in the school-based health centers come by way of screening from a general population, or at least a school population. That's about as specific as I would go, more so than from a clinical population. And now the clinical population is such a minority of the students that I see that I have to readjust my approaches when receiving those referrals. So I think we've come to our time. Thank you very much for joining us. Kevin, was there anything else you needed to say?
We just have a feedback. If you wouldn't mind clicking on the link I just put into the chat box. We'll also send this out by email for our post-session satisfaction survey. It just takes a couple of minutes, and it does help us to improve our programs. So thank you very much, Dr.
Thank
Rifkin.
you. It's been fun being back here giving a webinar again.
Awesome. Thank you.
Thanks for your help. And pardon me for forgetting the section at the end.